I am Claudio Cerchione. I work in Istituto Romagnolo per lo studio e la cura dei tumori di inamatori, located in Meldola, northern part of Italy. In ASH 2024, we have presented several data about personalized treatment in multiple myeloma, smoldering myeloma, from Istituto Romagnolo dei tumori di inamatori in Meldola, where I work. We have seen particularly poster about the combination of whole body MRI plus PET-CT in the idea of perfectioning the evaluation not only of bone lesions but also of extramedullary lesion and general soft tissue, and in particular we can see that in about 20-25% the combination of the two techniques can change the outcomes of our patients. So this is particularly important not only in symptomatic and relapsed refractory myeloma but also in early stage, also smoldering myeloma. So we can change our idea in sense of treating or not treating the patients, and relapsed refractory setting we could anticipate the treatment of relapse. I think that this data should be increased in a national study that we are trying to develop, but in general I think that today we should optimize the imaging approach in multiple myeloma also in order to optimize all the drugs that we have. Another poster that we presented is about radiopsy in multiple myeloma, the idea that imaging patterns that the patient show could be predictive of what's happening in terms of developing from early stage to symptomatic myeloma, the idea of pre-detect a relapsed myeloma, and I think that also this data that we are producing together with our colleague from health physics in our institution are particularly innovative, and I hope to see a development also in this sense with the larger number of cases. Moreover, we have presented the first preliminary data about biomarkers detection in multiple myeloma. We want to personalize the treatment, and we are working with the Sky92 molecular panel in which we develop these 92 genes to every patient who are in smoldering myeloma, newly diagnosed and relapsed refractory. We are going to see that this is more than important, but particularly it is superior to FISH, to classical cytogenetic in stratifying the risk of the patient, but potentially could be also a basis to imagine a biomarkers-driven approach in next future, because we want to detect biomarkers of response, but also biomarkers of sensitiveness. And in some way, we are going also to stratify patients in immunosensitive, chemosensitive, immunorefractory, and chemorefractory. I think that we should be ambitious, considering what we have reached in multiple myeloma. The next future will be to optimize and to personalize the treatment. Personalized means to understand which molecular patterns express that patients, and also to balance this with the characteristics of patient, elderly, fit, his comorbidities, previous treatment, and so on. Combining all these factors, we dream to develop a new prognostic score. This is maybe the next step after this data. So this is the wish that I give to our patients and to all the patients that are fighting multiple myeloma, with the hope that this prognostic score and this personalizing data could help to cure multiple myeloma. This is the best wish that I give to patients, to caregivers, and to all myeloma researchers. In Italy, we have seen a recent revolution in multiple myeloma. Currently, we continue to divide the patient in transplant eligible and non-eligible in terms of newly diagnosed, and daratumumab is the backbone in both the setting. Dara-BTD for transplant eligible versus Dara-RD or Dara-VMP in transplant ineligible patients. Waiting for the introduction of Perseus combination, Dara-VRD, and I hope also isatuximab that can be a game changer in this setting. The aim is to produce the deepest response, and I think that in transplant eligible but also not eligible in general in newly diagnosed myeloma, the real endpoint should be MRD negativity. Deep response correlates with the best long-term outcomes. In relapsed refractory setting, it depends from lenalidomide refractoriness. If the patient is lenalidomide refractory, we consider if he is sensitive to anti-CD38 antibody, and in that case we have ISA-KD when the patient is LENA refractory, or DAR-RD according to Pollux trial when the patient is LENA sensitive, has never been treated with anti-CD38. New drugs are on the horizon, and we have recently seen the reimbursement of selinexor Veldex, selinexor bortezomib dexamethasone according to Boston trial in patients who relapse after lenalidomide treatment or after DAR-RD. Could be a potential game changer according also to his comfortable schedule and also to his tolerability if adequately prophylaxed the patients. And we are going to see also bispecific antibodies in our real world. Recently in my country have been reimbursed both teclistamab and elranatamab, so we are going to use in our real world, and I hope to see as soon as possible also data from registries in both the molecules. Moreover, we are going to see melflufen that has recently reimbursed in my country for patients that in some way are refractory to immunotherapy or are heavily treated, and we want to switch to a very good tolerable molecule with a totally different mechanism of action. We know that this is a new kind of intending chemotherapy. Last but not least, CAR-T. We have seen that in this moment CAR-T are reimbursed in Italy. We are going to use in our real world setting. We have some issues with the institution's approval. I think that if we are able to make them democratic for every patient, they could be really interesting for every treated patient, but I hope that we will be able to anticipate as soon as possible. And all these novelties, I think, should be correlated with a deep changing also in our diagnostic. I think that MRD evaluation should be integrated in our real world. Some institutions do that. I hope that this could be more feasible everywhere in order to be able to in some way correlate with the real endpoint that should be MRD negativity, not only in front line, where is, in my opinion, essential, but in general in all setting. And the idea of treating early stage myeloma, smoldering high risk myeloma, in this moment inside the clinical trial, but I hope as soon as possible also in our real world. All this revolution with the best wish that we reach the cure of multiple myeloma as soon as possible. Wish to our patients, to their caregivers, and to all myeloma researchers. Thank you for your attention.